Absolutely. It's important to note that the CCC19, the COVID-19 and Cancer Consortium, is a huge global effort that many colleagues and myself have put together voluntarily because we want to capture more granular data in patients with cancer and COVID-19, try to inform those discussions in clinical practice, and the discussion needs data elements. And many guidelines nowadays just use consensus-based criteria, but we'll try to generate some data that can be useful to our providers and patients. So to meet this unmet need, we formed the COVID-19 and Cancer Consortium, and in this particular analysis that we presented at ESMO 2020, and I had the chance and honor to present in that meeting, we identified some prognostic clinical factors that appeared to be associated with higher all-cause 30-day mortality in patients with cancer and COVID-19. And those factors included older age, male sex, black race versus white race, multiple medical comorbidities, history of smoking, poor performance status, progressive cancer, as I mentioned before. Also, any recent anti-cancer therapy within 3 months, multiple, more than one malignancies, and also in a subset of patients who were hospitalized and they had available labs, we identified an exploratory analysis some laboratory variables that were prognostic, for example, lymphopenia, low lymphocyte count, neutrophilia or neutropenia, thrombocytopenia, abnormal creatinine, abnormal D-dimers, abnormal high sensitivity troponin, and abnormal cell-reactive protein. All of those labs that were abnormal were associated with a higher all-cause 30-day mortality in this subset of hospitalized patients. So there's definitely some interest here because based on those clinical and laboratory factors, some providers can evaluate this patient characteristics in front of them and get a sense of the risk of mortality in 30 days. The challenge we have is how to apply this data to make treatment decisions, because association may not mean causation, and there are a lot of confounding and selection biases in this analysis, a retrospective study based on crowdsourcing and surveys that were filled out by providers. So my practical question is, if I have a patient who needs treatment for cancer, do I go ahead and treat them? And my bias is yes. If someone needs treatment for cancer that cannot be delayed, we have to treat this patient during the pandemic. Obviously, this is a more individualized discussion with the patient, and have to be in these discussions in the context of pros and cons. This particular patient, the progression of the cancer, the surge of the pandemic, and individual other medical comorbidities have to be taken into account to help decide in an individualized fashion, customized way, whether this patient needs to get treatment or not. Just to give you two examples for our audience, if a patient needs treatment for the cancer right away because the cancer is actively progressing and need to control the disease, I think it's very reasonable to go ahead and treat the patient. If on the other hand you have a patient with very well controlled cancer, that this patient has been on checkpoint inhibitor for a year with a good response, this patient can potentially get a break, especially during the acute peak of the pandemic crisis. So it's individualized, but overall, I think our data shed some light in these prognostic factors. But again, there are many caveats, and it's difficult to inform clinical practice.